Hello, my cupcakes. How are you today? This is a very last minute live stream, so you did not miss any notifications. If you did not get a notification, it's because I literally just scheduled this like 5 minutes ago. I was watching the Take Care of Maya trial and I had it on. I've been running around all day. And Dr. Kirkpatrick is testifying now. He is, you may recall, those of you who are familiar with this case, he's the treating doctor of Maya Kowalski, the one who sent her for the, I'm going to call it a K coma in Mexico, the one who was treating her with these K treatments that caused Johns Hopkins Children's Hospital in Florida to believe that her mother was inflicting CRPS upon her, that she really didn't have CRPS, and that Beata, her mom, had MBP, which we are going to call MBP. Those of you know, if you know, you know. If you don't, you can type it out in the chat to someone. YouTube's rules keep changing and they're getting really, really fickle about what they're allowing me to say, what they're not allowing me to say. So we're just going to keep it on the safe side and try and keep our chat and our comments as classy as we can so that we don't get stricken. Okay, so Dr. Kirkpatrick, Anthony Kirkpatrick, has already started to testify. I want to take this back to, I'm going to rewind it to the beginning so we can watch it together. And this is going to be a really great example of what a difficult witness is. I've already watched his testimony for at least a half hour. Was anybody watching it live on another stream? Because he's a difficult witness. And in my opinion, this case hinges on his testimony because the jury is going to need to believe that he's a reputable doctor, that his treatments were reasonable, and a lot of other issues. But let's watch the testimony together, and then you can tell me what you think about Dr. Kirkpatrick and about what kind of witness you think he is going to make in front of the jury. So let's get going. We don't have a lot of people here, but it'll be nice and intimate. And I'm sure that as we get started, perhaps some other people will join us. If you are new here, I come to you with 30 years of civil litigation experience in New York State and federal court. I am what I like to call a recovering lawyer. I am also a legal analyst, YouTuber, and mother of 5 and working actor when there are no strikes in progress. So right now, let us go to the courtroom in Florida where the Kowalski versus Johns Hopkins Children's Medical Hospital case is ongoing. It's been ongoing for many days. I don't know if this is day 10, 11, 12. I'm not even sure. Maybe somebody in the chat knows, but we haven't watched it live together yet. So I thought today is a great day to watch it because Dr. Anthony Kirkpatrick is on the stand. And from what I have already seen, he's a hard witness to control. So this is going to be challenging for the plaintiff's attorney and maybe a field day for the defense. When I prep my clients for depositions, I always tell them the following. This is my instruction to every witness that I either have a deposition with or that I put on the stand. Answer only the question. Remember these rules that I'm telling you now. Answer only the question. If the question can suffice with a yes or no answer, your answer is yes or no. Do not volunteer information. Do not go off on tangents. Do not help the other attorney do his or her job. You answer only the question. We're going to see in the beginning of his testimony, so far I've seen a lot of times where he's already needed to be reined in. So let's watch it. You guys ready? All right. So this is going to be Dr. Anthony Kirkpatrick. And we are going to watch it on a local Tampa station. Let's see, let's go like this. All right, just let me know that you can hear it. They brought Dr. Kirkpatrick in before he was sworn in. There were some arguments made by both sides that 2 audio recordings that Beata Kowalski made during visits to Dr. Kirkpatrick, which Beata recorded audio only, whether or not these 2 audio recordings are going to be admitted into evidence. The argument was that if Dr. Kirkpatrick did not consent to Beata recording him that they should not be allowed into evidence. They couldn't agree. So the judge called in Dr. Kirkpatrick to the stand outside the presence of the jury. He was questioned about those recordings, and he admitted that he did not give Beata consent to record him during those 2 visits. They have therefore been excluded from evidence. They are not going to be allowed to be admitted. These are recordings that the plaintiff wanted admitted into evidence. And because Dr. Kirkpatrick said he didn't give her consent to record him, they have been excluded. I don't know what was on those audio recordings, but my guess is that they were helpful for the plaintiff, so this could hurt them. All right, so Dr. Kirkpatrick has been sworn, and he is starting his, okay, Mary, hi, Mary. Dr. Kirkpatrick is the treating doctor of Maya, who is a CRPS specialist who prescribed the K treatments for her. Please don't spell out that entire word into the chat or into the comments, because it's not a word that YouTube likes and they're gonna strike me. So K treatments, you remember she went to Mexico where he induced her into a K coma for several days, and she had some improvement. And because of these treatments, and because when she was admitted to Johns Hopkins, and because Beata was insisting that Maya needed K to help her pain, that is why DCFS was called. That is why the CA abuse hotline was called on Beata, saying that we think she has MBP. We don't believe that Maya really has CRPS. And that is where this whole mess started. So Dr. Kirkpatrick is Maya's treating doctor. That's why I think his testimony is so important. And that's why I am taking it back to the beginning of his testimony so that we can watch it together. Here we go.
Sworn. Well, I appreciate that.
Please state your name for the record.
Anthony Kirkpatrick.
And where do you live?
My home address is 849.
No. Don't tell your home address.
Yeah, we're on.
Okay,
Yeah.
sorry. Hillsborough County, Tampa, Florida.
All right. And you are an anesthesiologist and pain expert.
Yes.
And how long have you been in practice?
It's over 40 years. Plus, I just don't know exactly, but it's at least 40 years. I've been practicing anesthesia.
And you were the physician who first diagnosed CRPS in Maya Kowalski.
Correct.
I'd like to give you to give the jury a brief summary of your background, training, and experience towards what you'll testify to here today, beginning with your undergrad, if you could.
Okay, I'll try. So I got my bachelor's degree from the University of San Francisco. From there, I went on to get a master's degree from the School of Medicine in Portland, Oregon. And perhaps I should clarify or explain what pharmacology is. It's not pharmacy. It's where you go in and you learn how to develop drugs in clinical settings. You teach in medical schools, which I've done. So that's pharmacology. So from there, I decided to go on and get a PhD degree in pharmacology, and that was from the State University of New York. From there, I began teaching. I actually went to Stanford for a while to do some research, and then I ended up teaching at the University of Nebraska, teaching pharmacology as a PhD. And then I went back and had an opportunity with the courses I had to get advanced placement at Ross University, which is located in Dominica. And there I took some courses, but the main part of my training took place at the University of Miami in the School of Medicine as a medical student. And I got my MD degree. And then while I was there, I was invited to give lectures in pharmacology to the anesthesiology residents. And from there, the chief of the department suggested that I might want to do a residency in anesthesiology. I took him up on the offer. Now, we're going back over 40 years ago. And so at that time, the residency program was only 2 years. It was a very abbreviated type of residency compared to what it's now. While I was there, I began to develop an interest in the area of pain and how to control pain better as a resident in anesthesiology. From there, with my PhD degree and my MD degree, I accepted a position at the University of Illinois in Chicago. And in that capacity, I had an opportunity because of my PhD degree to do some clinical research, national multi-center studies all over the United States. I'm not going to go into the details, but on a drug which is still used today. It's called esmolol. It's a drug. It's very rapidly acting. You can control the heart rate during surgery, that sort of thing. So I set up the studies for that nationwide, worked directly with the FDA and all that sort of thing. In the meantime, I accepted a position as an assistant professor of anesthesiology at the University of Illinois in Chicago. And I continued my interest in pain there and got involved in, I'm not going to go into all the details, but some research on local anesthetics and so forth. But also while I was there, I developed an interest in pediatrics in anesthesia.
All right, tell us about that.
Okay, so we had one of the branch hospitals in Chicago focuses on ear, nose, and throat and eye surgeries. And they needed someone to kind of set that up so that one of the eye surgeons in particular wanted to be able to anesthetize, completely put to sleep under general anesthesia, children. And they didn't want them laying down like we normally lay kids down to do the general anesthesia. He wanted to be vertical because the instruments he had to look into the eye for diagnostic purposes were not suitable. So I tried to figure out what kind of drug to use in those circumstances. Because when you go vertical, the blood in your head goes down to your legs more or less. And I needed a drug that would keep the pressure up. And of course, ketamine does that. It's the only general anesthetic we have which supports pressure. It's the only general anesthetic we have which supports breathing, so I wouldn't have to sit there and ventilate the patient.
Right, during the procedure.
During the procedure. So I put the patient in my lap and teach the residents how to give general anesthesia while you got a child sitting in your lap. And so that technique was developed. I spent a lot of time there teaching residents in anesthesiology about dealing with the pediatric population. From
how'd you get involved? Okay, so we're there. How did you get involved in the actual pain management part that led to RSD?
Right.
Yes,
Right.
they're allowed to take notes.
The way that I got involved is that I was interested in a local anesthetic that would last a long, long time. There was a doctor there in the Department of Pharmacology who was dealing with these little teeny microscopic capsules of anesthetic that, because it was encapsulated, would release the anesthetic very slowly. And so we went ahead and got a company started to develop that so that that could be used to give a longer acting local anesthetic. So that is where I got involved with the pain because that was the target. That was the clinical application we wanted to use. And so from the university, if I can move on.
Yes, I wanted to ask you
Sure.
a few questions in the interim. I forgot. You've received certain awards in your career, have you not, for your medical service?
Yes.
You received the Governor's Award from then Governor Bob Martinez for contributions to science and technology,
Correct.
1989. The Abbott Laboratory Award for excellence in chronic pain, involved the Department of Anesthesiology, University of South Florida in 1990. Is that right?
Correct.
The Governor's Award for leadership.
Your Honor, leading.
Well, it's faster.
for this purpose, I'm going to allow it overruled.
Yeah, because if he doesn't allow him to start leading, this guy's going to ramble on forever. That's the problem. He wants to get his qualifications out, but he needs to really kind of help him because now he wants to get to his awards and his accolades. And that's all pretty important. This guy is the treating doctor, remember, of Maya. He's the her pain doctor, pain management doctor, Dr. Kirkpatrick, who did the K treatments and took her to Mexico where he did the K coma. We're calling it the K coma for those of you who are just joining.
Governor's Award for Leadership at the University of South Florida College of Medicine, presented by Governor Jeb Bush in 2002. Is that correct?
Correct.
And then a Dean's Award for Outstanding Service to the University of South Florida, presented by Dean Robert Doherty, MD, in 2002. Is that right?
Correct.
When you started out, was there board certification the way we know it now?
No, not at all.
So continue now. We want to get to the RSD Foundation and what you did starting with that.
Sure.
You can jump ahead.
Okay, remember RSD is what CRPS was formerly known as. They changed the name to CRPS at some point, but it was formerly known as RSD, reflex sympathetic dystrophy.
You and Dr. Schwartzman.
Oh yeah, right. So from Chicago, I went down to the University of South Florida School of Medicine. Took a position there in the Department of Anesthesiology. And it was during that time, I was fascinated, really fascinated by this syndrome. We call it a syndrome, complex regional pain syndrome. I was fascinated by it. And back then, most of these patients were accused of being crazy, crazy, because there isn't any like a laboratory test you could do to make a targeted diagnosis like diabetes and so forth and so on.
What year were we talking about, approximately?
That goes back to 1988.
Okay, so that's really important. I'm going to keep stopping just because I need to give commentary, but also because we're behind anyway. But for him to say that CRPS was oftentimes people were told that it was all in their head is really, really important. And I know that we have a lot of viewers who are suffering with CRPS who will tell you that same exact thing, that oftentimes patients were told that they were crazy, that it was all in their head, that there's no way that you could possibly feel this type or level of pain. And so that's really important testimony for him, that this goes all the way back to 1988, where doctors, many medical providers thought that people who were suffering with CRPS were crazy. That's what his testimony was.
Please continue.
Yes. And so I was fascinated by that. And I became friends with a Dr. Robert Schwartzman. He came to the university to give a talk, and we made. He is a neurologist, and I'm an anesthesiologist. And he...
I object to the bolstering into the hearsay and appeal to authority of this without a foundation.
Why don't you ask more specific questions,
Yes.
Mr. Anderson?
Who is Dr. Schwartzman when it comes to the development of treatments for CRPS?
Judge, same objection. This is involved.
Overruled on that one.
Good.
Yes,
Let's
Dr.
be all
Schwartzman is probably considered the most highly published individual in the field of complex regional pain syndrome. Back then, by the way, it was called RSD, reflex sympathetic dystrophy.
Is that still used?
No. We finally got people to stop using that, but no, it's not used anymore.
Is there more than one kind of CRPS?
Yeah, we divide it down into basically type 1 and type 2 complex regional pain syndrome. Type 1 means there's no major nerve injury, at least evident.
Right.
And type 2 is where you got a major nerve injury. You knocked out your brachial plexus, your sciatic nerve, something like that would fall more into type 2.
What studies then did you and Dr. Schwartzman begin towards treatment of CRPS with ketamine? How did that work?
Well, it actually started with ketamine, and that goes way back, way before 9/11. And we were trying to see if we could. There was some reason to believe it has this target the nerve pain. The pain is coming from within the nerves itself, as opposed to the type of pain you get when you injure yourself. Substances are released into your tissue, causing pain. When you get an ulcer that's inside your body, the same type of mechanism. It's not inside your nerves; it's substances released that trigger the nerve. And those are the ketamine targets the nerve pain inside the nerve itself. Whereas these other mechanisms we talked about, the injury type and the type that you get with an ulcer, those types of pain processes are not very responsive to ketamine. To do that, you almost have to. Well, you get pretty close to putting people under general anesthesia to really control the pain.
So tell us how the studies went. How did
Oh,
it get
sure.
developed?
Keep the eye up there, be very close.
Oh, I don't know what that noise is, but it's not coming from me. It's coming from them. I mean, so far we've learned that he's highly qualified. Seems to be an expert in the field of CRPS. He's a little quirky. He's a little quirky. And I don't know, if the jury's going to respond to that or not. So we'll see.
So we can get up to Maya Kowalski now. These results of the various studies that you performed indicate that ketamine was useful in the treatment of CRPS.
Yes, in the beginning it was not doing what the patients call ketamine coma, being put under general anesthesia for 5 days. It was the low dose conscious sedation. The patient's awake, they can talk to you, but you're giving them ketamine. It's called conscious sedation.
So how did you discover this other procedure involving putting them under anesthesia?
One of the things we learned is that the benefits from the ketamine it's dose related. The higher you get the dose, the longer the response, the more vigorous the response. But there's a limit to how far you can go and still keep the patient conscious. There's going to come a point where you start to lose consciousness. And when that happens, the thing we concern ourselves with is protecting the airway, especially in children. Because children, when you give them ketamine, they tend to salivate a lot. So that saliva we all have is okay in your mouth, but it's got bacteria. It's not so okay if they get into your lungs. We call it aspiration into your lungs, and that can cause pneumonia. So remember, we're talking about conscious sedation. The patient can talk. They don't have a tube, an endotracheal tube, into the trachea to protect from the saliva going into their lungs, but they're awake. Your reflexes keep the saliva into your mouth. It's a protection we all have.
All right, so how did the intubation, general anesthesia, infusions work?
Sure. So to do a research study, you really need numbers. Well, he had some patients there that were, now we're talking how we progressed it. I'm sorry, is that what your question? How we?
No, I wanted to get across to the jury whether it was effective or not. The procedure, once perfected, whether it worked.
Yeah, it worked. It worked in the vast majority of patients. Conscious sedation with ketamine works. It gets them controls their complex regional pain center, the vast majority of them.
Now, and in the studies that you did regarding the general anesthesia, were you under a review board at that time?
Yes, all studies that are clinical in nature, you have to get it done by an institutional review board. And at that time, we decided that it would be done by Drexel University, where he was professor and chairman of the Department of Neurology.
I'm trying.
Sustained.
So, doctor, now, did you ever have to turn in to the institutional review board any bad results, for lack of a better term, out of the study using the anesthesia infusion?
Never had it.
Sustained. You need to move on, Mr. Anderson.
Yes, sir. All right, so, Doctor, did you begin private practice in Tampa, St. Pete area, and when?
Oh, well, no, I've been based in Tampa.
Okay,
And so, no, my practice has been primarily in Tampa.
okay. And so when did you start treating patients in the Tampa Bay area?
That's when I arrived at the University of South Florida. That would put us at about 1988.
Right. And when did you stop actively treating patients as in an anesthesia practice?
Well, I'm still practicing.
Okay. All right. So how did it come about that you met Maya Kowalski?
Okay. From what I understand, the mother, Beata, had heard about me through her contacts. Her mother is a infusionist nurse, and she'd heard from some of the other patients about me, and that at that point in time, there had not been a diagnosis, and the family really felt there was something desperately wrong with their child, and they needed another opinion, and they wanted to look at this possibility by consulting with me.
And was your first visit, I know you don't have your records in front of you, was your first visit on September 23rd, 2015 then?
Correct.
So tell the jury what you did on your first, the first visit.
Well, I have a policy, and that policy is that you always tell them how long the evaluation is going to take.
Right.
In a situation like this, it usually takes at least an hour to get through an evaluation. And I tell the patient the first thing I'm going to do is they fill out this we call the new patient information form. And I'm going to go, before I talk to them, I'm going to go over that material and see what I can get sort of a background of what I'm going to be confronted with.
Now, Doctor, when your new patients come in, are you like just trying to confirm that it's CRPS, or are you looking for whatever the diagnosis is, CRPS, or it could be something else?
Well, you have to do the latter. You have to look for everything, because that's part of making the diagnosis. You have to rule out all the other possibilities based on the history, based on the symptoms, based on the signs that you witness. You have to be able to rule out these other potential diagnoses, or at least you can come up with a differential diagnosis may include more than one thing wrong with the patient.
Do you then try to avoid what is known as a confirmation bias? That is, everything that comes to the door is presumed to be CRPS until proven different?
Well, confirmation bias. No. Well, you have to fight that.
Right.
You have to fight it. You got to say, I'm here to help the patient. You can't help the patient if you're not can I use the phrase, an honest broker?
Got it.
Okay.
All right. So how did the examination of Maya go?
That's important too, because the defense is going to try to say that he has confirmation bias because he doesn't take insurance. His treatments are very expensive, and they are going to try and paint a picture. In my opinion, this is what I think they're going to do. We'll see if I'm right. They're going to try and paint a picture that he's looking for CRPS in order to prescribe these K treatments that are very expensive, and that he's just money hungry. So we'll see. But he just said that he tries to rule out everything before he makes that diagnosis.
Well,
How did
she was in a lot of pain, and after a while working with children, you kind of learn of a way to communicate, to get them to relax and try to bring it down. At 10 years old, it's a challenge, but it can be done. You can try to get it down so they know that they're part of the discussion with the mother.
Right.
So we work hard to do that. And I also invite the child to be part of the discussion. So the first thing we do is most time when I look at the new patient information form, it's something like this, and it's incomplete.
Mm-hmm.
So I'll go through it and I'll fill in the blanks with them as we go through it.
How did Maya appear to you in terms of maturity and intelligence for being 9 or 10?
Remarkable. It's not just intelligent. It's curious. She wanted to know. She's listening to what her mother says. I wish you got a child that's a little unique, different.
Right.
Not a little, a whole lot different.
Mm-hmm.
So she's intellectually curious, very much engaged in the conversation.
So did she contribute then in going through and filling out, finishing the questionnaire?
Yeah, they both contributed to that process.
All right. So after that, what steps did you take to examine the child?
Well, I have a pretty much a head to toe type of examination, because remember what I said, you got to look for all the possibilities here, not just one thing
Sure.
that you've been doing research on. And so the first thing, like I say, I want to take a history. History is very, very important. I mean, the history is very important. So you're looking for, the whole history. Did it come from, how did this start? And then you go and work through all that process. And so you try to fit all that together and see if you can narrow it down a little bit, what's going on. And then, of course, there is the examination that takes place. And there I have a pretty standard thing from head to toe. It doesn't just look at just the one area. And then another thing I do, and this is something that I'm very compulsive about, is I want to set things up and do things that leave me convinced that I've done a very objective evaluation.
And what does that involve?
Well, that involves fighting the tendency to want to be biased. I mean, we always want our patients to do well, right?
Right.
All right. So I try. One of the things I did since I started running the surgery center is I set up a new technology or a new methodology for measuring pain, not by numbers. You've heard this whole thing. Is it a 1? Is it a 2? Is it up to 10? 10 being the worst pain. That's for chronic pain. It's almost useless. For acute pain, it can be helpful. But for chronic pain, in terms of doing research, it's not very helpful. So I wanted to find a way so I could measure, without even talking to the patient, how much pain they're feeling between their earlobes.
And what did you use?
And what I used, I brought it today. I can show you if you want to see. It's a device called an algometer. And what it does, basically, first let me back up a little bit here. When you get CRPS and some other diseases, what happens as time progresses, maybe not initially, the body changes from being a local phenomenon, like you hurt your hand or whatever, sprained an ankle. It tends to progress into the central nervous system and into the whole body, the brain, everything gets involved. There's a word for it. I'm going to throw the word out and then forget it. Hyperesthesia. You'll find it in what they call the Budapest criteria. It's one of the things you're looking for when you do a diagnosis. Hyperesthesia.
All right.
And what that means is that all your senses, touch, sound, hearing, smell, they get accentuated so that you become very sensitive. So it was common for Maya to come in with dark glasses on because the bright lights were painful to her. But when she came in, the one thing that stood out more than anything else is her skin was exquisitely sensitive to light touch. Again, I don't want to use the big words for it, but I don't know. I don't know what other people have said.
They've been well educated.
Have they?
about
Because
CRPS
I don't know what other people have said so far, but it's called allodynia. Okay. And it's like defined as any type of tactile stimulation, light touch, blowing on the skin is perceived as being painful. She had that. She had a bad case of it.
What other symptoms or signs did you know?
Well, she had the allodynia. But the point I want to make is you can touch them and figure what this technique is called measuring pain thresholds allowed me to not only just detect it, but to quantitate the magnitude of it, of what she's feeling in her brain. And this device, by putting pressure on the skin, it gives you a number. It's called the pain threshold. So I tell the patient, look, I'm going to apply this device to your skin, and it'll feel like pressure. But I'm going to increase the pressure, and when the pressure turns to a pain signal, say stop. And we do it 3 times just for statistical reasons. 3 times we do that, and we get a number. And from that, and oh, by the way, one other thing is very important: they're blinded. I mean, they don't see the numbers. They don't see nothing. So this is what I mean by being objective. So if a child comes in, let's say, whatever, they want to stay out of school, so they're faking their pain, whatever, I can tell without even talking to the child if they are or not by doing this the pain thresholds. It's a way to distinguish between what they're feeling in their brain in terms of pain signals as opposed to what's an emotional issue that might be evolving.
What, if any, other signs or symptoms were noteworthy during the initial evaluation?
That is really important testimony too, because remember, the hospital thought that Maya was making it up, didn't believe that she was in really as much pain as she was complaining to be in. So the fact that he can do that test, and what he just said is that he can tell if a child is faking, could be very, very pivotal testimony in this case.
Evaluation.
The other thing that was noted, besides the generalized, the seeing problems and the touch, not just in her legs, but in her arms and so forth, measured with this device,
Right, but,
was the dystonia.
okay,
Dystonia is when the muscles contract due to the disease. Usually they're curling in. Sometimes they'll actually stretch out, but mostly there's flexion.
they
And
know
it can
about
happen in the
dystonia.
hands or in the legs. The interesting thing about it is when it comes to comparing adults with children, we rarely see it in adults, but we see a lot of it in children. So if a child comes in with dystonia, you got to be thinking about CRPS.
Anything else in terms of signs or symptoms, first from the examination, and then I'll ask you about the history.
Yeah, well, I think in terms of examination, of course, we try to measure temperature of the skin, and we're always comparing the one side with the other. When the sympathetic, and like I said, I have to go back a little basic. We knew from the very early, 30, 40 years ago, that this is a disease involving the sympathetic nervous system. And usually it's symmetrical on both sides. Your temperature is pretty much the same on both sides. But when you get the CRPS, things get disconnected so that one side may be cold, the other side may be hot. So I took out a device, which I brought today, if anybody wants to see it. It's called an infrared scanner.
He keeps offering up his props. I don't know if anybody asked him to bring props today, but it could open up a lot of questions for the jury, because remember, in Florida, the jury is allowed to ask questions of the witness. So there was some testimony earlier today where the jury had questions for the witness and we're allowed to ask them. So we'll see how this plays out with his props.
And so again, I want objective information. So it measures down to 1/10 of a degree. So I measure for differences in temperature. Now, on this particular occasion, there was some difference, but it didn't reach my satisfaction for a significant difference from a medical standpoint. So I didn't record that, there was a difference in temperature.
Okay.
Keep in mind that this is a disease that's labile. You come in one day and there's a difference. One side's warmer, one side's colder. If you think about it, there's going to come a point where they're kind of they're the same when they're fluctuating like that.
Any other signs or symptoms from the physical examination that you can think of?
From the physical, let's see. Yeah, there were, yes, they're on the right side. Now, with this device, I'm able to tell you which side is worse, the algometer. I'm able to tell you which, her right side was worse with the CRPS, the sensitivity, and she had lesions on that side. And they typically are like, they look like little dots almost sometimes, but they sometimes will break up and then they actually become an ulcer where they breaks through the skin.
Right. Okay. And then very, very briefly, the history given, what was significant to you now that you had these physical signs?
Well, for me, there's some things that just glare at you. Hey, this is CRPS, complex regional pain syndrome.
Right.
The main thing is allodynia. There is nothing we know in medicine that causes this exquisite sensitivity to light touch than CRPS. There doesn't exist. Okay, doesn't exist. And so that just right away, that became a very big deal. And of course, like I said, in children, the dystonia when they get CRPS is so common that there. So putting it all together, the dystonia, which is a sign, and the which means she couldn't walk. She couldn't bear weight.
She was in a wheelchair?
And she was in a wheelchair. And she had the real sensitive skin, which you couldn't touch in certain areas, especially in her lower extremity, especially on the right side.
Let's jump ahead. So you made the diagnosis of CRPS.
Yes.
and you confirmed it with your testing.
Yes.
And so how did Beata present to you through this initial evaluation, the mom?
Well, it's
Okay, let's listen to how he describes Beata, because this is also going to be important, being that the hospital immediately thought she was crazy and had MBP and was making up all of her daughter's medical problems. So he, who started treating Maya in September of 2015, I think his impression of Beata is going to be important here.
kind of funny because I was talking about Maya being so intelligent and so inquisitive, and that's her mom. They have the same DNA,
Yeah.
you know. She's the same way. She wants to know details. She's very medically oriented, and I like that. And to me, it's refreshing to have a patient that gives you a little bit of a challenge. I enjoy that.
Did you find her determined or any other characteristics?
Well, she loved her child. I mean, she loved her child. And you know what? The child loved her mother.
That's always a good thing.
Yeah.
All right. So now you've made the diagnosis. What did you prescribe?
You can see the people in the gallery getting choked up about that. She loved her child, and her child loved her mother.
As the initial, strike that. Did you check to see what different therapies Maya had already been through?
I did, and I looked at particularly those places where she had the usual, customary treatments for CRPS. Physical therapy, maybe occupational therapy, and cognitive behavioral therapy. Those are the big things that you think about in the beginning. And I did think about those, and I did explain to them during the evaluation. Our job is to get the legs moving. If we don't get those legs moving, especially what we're looking at right now, it could, well, she asked me what could it be, and I told her the truth. She could form blood clots in her legs, and they could break off, go to her lungs, and it could be fatal. And the problem with that in children, especially in children, it's a silence. It's silent. It's hard to diagnose because in adults, when we get a pulmonary embolism in our lungs, you get chest pain, you get a feeling of apprehension, something ain't right. Kids, they just don't wake up in the morning. So that's one problem. The second problem is if they do get it, it's hard to treat. Why? Because remember what I said, they have the allodynia in their legs. Normally what we'll do is put them in pressure socks. Their skin is exquisitely sensitive to light touch. So that limits your treatment options in that situation.
So what type of therapy did you suggest or prescribe to start with?
I told her that if she can possibly get into some heated pull exercises, that would be recommended.
And did the Kowalskis follow your prescription, if you will, and find ways to heat up their pool?
Yeah, I understand they set up some kind of a solar system. Yeah.
So how long did the warm water therapy last, the best of your knowledge, before they were asking you if there's anything else could be done?
Well, I think they came back and because I don't have the evaluation here in front of me, but they came back and she had a kind of an exacerbation of her symptoms, and then taking, and this is important, taking in consideration she's exhausted in moving forward with her symptoms and problems medically with the usual customary treatment, the physical therapy, the PT. And by the way, if they don't know what they're doing, PT can actually make you worse.
Right.
So they tried all those things. In fact, she spent a month, I think it's about a month, at Tampa General Hospital. Right. I know their program because I was there for over 20 years. I think it's 20 years. I was there for over 20 years on the attending staff there.
Yeah.
And I know the program, and that's what it is. And so they've been through all that, the psychotherapy, all that, and she was just getting worse.
So what was the next step for a reasonably prudent physician,
right,
pain physician at this point?
Right. Having had the experience of doing those, over that 2-decade period, we've done a total of probably, let's see, we've probably done, well, be exact, 43 patients with the ketamine coma. I didn't think of that right away. That was not what I thought about. What I thought about was, let's try a low dose conscious sedation where she's awake. Now, mind you, and this is I explained this to them because her mother asked me, you said, Dr. Kirkpatrick, that she will lose her memory temporarily, short-term memory. How long does it last? That's what I mean. That's the kind of mother she is, okay?
Right.
She's asking questions all the time. And it's temporary. But it's important that we give enough ketamine, because remember what I said. It's dose dependent. You have to get the dose up. So we want that temporary loss of memory.
Is that part of
But-
the resetting process?
Right, exactly. And so we don't want to get the dose so high for safety reasons that the secretions could end up down in the lungs. So the way we prevent that is they're always conscious. So they do not lose their long-term memory. Who's that over there? Well, what's her name? That's my mother. Or the mother is actually there in the room with the child. That's another thing we found very important. Children, it's really important, kids, to have the significant other there. If it's a mother or father there in the room, because what happens sometimes, they start feeling the room's getting bigger, getting smaller, they get a little frightened. There's the mother over there. Dr. Kirkpatrick isn't trying to poison me. I know who that is. That's my mom. She's here to protect me, because you do lose your sense of it. But kids, we knew this for decades. Kids don't really hallucinate the way adults do. Adults can get really bad hallucination. We rarely see it in kids, rarely. But nonetheless, the point is, mother's there, and we constantly ask them, what state do you live in? What country do you live in? So we always are communicating back and forth to make sure we don't overshoot.
I'm trying to move along.
Response to a question here.
Yes, Dr. Wilson.
Yeah, remember is my volume better now, Maja? I turned it down a little bit. I don't know. It was weird. I have it on to set automatically, but I don't know. Remember that the attorneys have a time limit in this trial, so they are up against the clock. And if your witness starts rambling, it's killing your time. And you have certain things you want to get out of the witness. So if he starts burning the clock, he's not going to be able to get the things out of him that he really wants to get out of him. But I also thought that thing about kids not hallucinating was interesting, as much as adults do, because somebody in the chat, I'll pull up the comment later, said that he was hallucinating when he was given K as a treatment before some sort of procedure.
We'll try to confine the answers a
Sure.
little more to the questions. I know you have a lot to say on this. How many different infusion sessions, if you recall, did Maya go through? The outpatient type, if you will.
Yeah, there were 4, and they were 4 hours each.
All right. And the dosing, do you remember what it titrated up to?
Yeah, I just happen to remember 100. It was about 135 milligrams per hour. Yeah, about that.
And what were the results?
The results, there was some evidence of improvement, but in the legs, which concerned me the most because of the possibility of pulmonary embolism, there was hardly any movement at all. That was my biggest concern. And I think the time is ticking, because a pulmonary embolism is something you can say, well, it's going to happen 3 days. It can happen at any moment, and you got a crisis on your hands. So that made some sense of urgency to the situation.
So how did you then respond if your outpatient infusions are not working? What was your suggestion?
My suggestion was that based on my experience of having done other kids with the high dose, the anesthetic dose of ketamine for 5 days, that would be something for them to consider carefully. And the way I wanted to make that happen is I put them in touch with some other children that we've done in Tampa. I mean, from our surgery center, and they've given permission to disclose their name. In fact, they posted their stuff up. But the point is, we had 2 kids that had gone down to Monterrey, Mexico, that had that done, and so I put them in contact. I said, don't make a decision, talk it over. I put you in contact with Dr. Cantu down there. Here's his phone number. I will send him all your records if this is something you want to do. And we do go through This is not a research now. Keep that in mind. This is about treating Maya out because she needed some urgent care to protect her.
Let me ask you about your relationship with Dr. Cantu and his clinic there. Do you get referral fees or anything out of this?
No.
And do you do?
Okay, that's important too, because Dr. Cantu is going to be the one in Mexico who does this Coma for her, and he does not get referral fees from Dr. Cantu. I think they're going to try, perhaps one of their arguments would be, well, listen, you're getting kickbacks every time you send somebody down there for a Coma. So there goes that theory. But let me just jump to the chat for 1 second. We'll take a break from him for 1 second, right? So that we can go to the chat. Yes, I did start the memberships. I put them up like on a soft launch just to get them out there because I had my daughter make me the cupcake logos and the special emojis. So thank you to everybody who's already joining. This is crazy. Thank you, Robbie, for becoming a new member. And thank you, Galen, for becoming a new member as well. And Robbie, I see you also sent me a super chat. Thank you for loving the channel. There are great people on here. We are building a really, really great community. Love all of you guys. So let's go. I think we have the link up. Amber, thank you. I know you already joined the other day. You were like number 2. Aunt BB2, I think, was number 1. And then number 2. Thank you so much. Yeah, I don't know. Google might block the join button on the phone. I don't know. You might have to do it from a laptop. Okay. We'll get to the questions in a little bit. Let's let him testify a little bit more. If you have any questions, keep them and we'll save them for a little bit later. Otherwise, they get kind of lost in the chat and then I can't address them.
Do a I guess before they fly down there, do you do an examination to see if they're physically ready?
Yes.
And you get paid for that.
Yes.
So then they decided to do that, to go to Mexico?
Yeah. Well,
where else is it offered, by the way, besides Mexico? Is there any place else?
No, to my knowledge, at that time.
Had it been offered in Germany before?
Well, Germany, as far as I know, it's so far away, and so Dr. Schwartzman and I decided to move in another direction.
Got it.
And the other thing about it is Dr. Cantu, again, I don't want to spend a lot of time on this, but he had a patient he wanted me to help with. I flew down there to help him with the patient, put that patient under general anesthesia with ketamine for a week, and she did fantastic. And so with that, we decided to try to get institutional review board approval to do patients in a study.
Dr. Kirkpatrick, I really need you to answer the question that's asked. And I know there's a lot of other information, but it's important that you only answer the question that's asked and not throw in additional comment.
I understand.
I appreciate it, Mr.
We're on limited time here. Okay.
As plaintiff attorney looks at his watch, taps his watch and says, we're on limited time here. That's really his job to rein in his witness. He needs to stop him. The judge should not have to step in to do that. He should be the one saying, Dr. Kirkpatrick, let me redirect you, please, to answering only the question that I'm asking you.
So, did you speak with the Kowalskis or otherwise find out how the ketamine infusion down in Mexico went after they returned?
Yes.
And how was it?
It's great. She started moving her arms and she had full function of her arms. She could take care of herself. She could comb her hair, brush her teeth, eat with her hands, and so forth.
All right. Now, was it necessary at this time do you terminate the ketamine infusions, the outpatient, or do you try to keep up with these? And if so, why?
Well, we have found over the years that sometimes these patients, after they have, not all of them, but some of them, after we do them, they have to have what they call it a booster. Okay. They come back. Remember what I said, it's the conscious sedation. They are awake when you do it.
Got it. So they need a booster.
A booster, yeah.
All right. What about after the booster and they come back to the United States? In Maya's case, did she continue with ketamine infusions as necessary?
Yes, she did.
And who did you refer them to?
Dr. Hannah.
And why Dr. Hannah?
Well, we're a research center. Again, trying to keep this succinct as I can.
Okay.
Please. We're a research center, so most of my patients are coming in and they're paying out of pocket cash.
Okay.
And the reason for that is we can't do research unless we have money, and that money comes
Well,
from.
hang on. Let's
Okay, sure.
just stick with that. And so then why Dr. Hannah? Because you're a research center and you're not set up for
For insurance.
and for long-term infusion, I mean, to keep going steadily as necessary.
Right. And the other reason, I knew him well. He's my next door neighbor across the bridge.
Okay.
I knew him. I've been to his facility. I know what he does. He's one of the most caring doctors I've ever met when it comes to patient care.
And so then, were you aware at this time that Maya had eventually had a port put in to facilitate the infusions?
Yes,
And do you know what hospital that was done at?
Johns Hopkins.
If I could show, publish in evidence 2041-036. I believe this is from Dr. Elliott, I think. Is this Elliott's? Zero three six. You know what? I'll move on. You guys, let me know. All right. So, Johns Hopkins actually put the port in.
Correct.
And through the course of 2016, did you ever receive a call back, leaving out eventually, the October events? But did you ever get a call back from anybody at Johns Hopkins that was questioning or concerned about Maya having received the ketamine treatment
No,
in Mexico or with Dr. Hannah?
no.
And to the best of your knowledge, how was Maya doing over the course of the spring and summer?
When she came back from Monterey.
Yes.
Yeah. Oh, she was, well, I did evaluate her when she came back,
Okay.
and she had full function of her upper extremities. I don't recall there being any.
Excuse me, Council, I'm sorry, can we get a date on this?
When?
When he's talking about evaluation he did, I'd like to know what date it was.
Oh, sure. Doctor, did you do an evaluation in 2016 or was this from accounts reported to you?
I did do evaluation. It was about 2 weeks after they came back, roughly.
Okay. All right. Okay. So through the course of this time then, nothing from Johns Hopkins. And then did you learn that Maya had had a relapse in the late, well, I guess it would be early fall, very late summer?
I think I did, and I don't know how I got the information, but it
I
had,
don't have the source, you don't have the source of information here, this appears to be hearsay. He's testifying to third-hand information.
Madam Clerk, can I have the question back, please?
It's a hearsay objection.
Question, okay, all right, okay, so through the course of this time then, nothing from Johns Hopkins, and then did you learn that Maya had had a relapse in the late, well, I guess it would be early fall, very late summer?
I
Overrule the objection. You can answer.
I can't recall that specific. The one thing, well, anyway, I don't recall something of that nature. I think there was, but I'm not absolutely sure about it.
Did it come to your attention that Maya was checked into Johns Hopkins All Children's Hospital in the fall of 2016?
Yeah, yes, I'm aware of that.
All right. And did there come a time that you had a conversation with one of the doctors there? Did you ever have a conversation with Dr. Smith?
Okay, this is regarding his conversation with Dr. Sally Smith when Maya was admitted to Johns Hopkins, when they accused Beata of having MBP. He's going to now testify as to his conversation with Sally Smith, who you remember was the CA doctor who was part of the privatized DCFS system in Florida.
Yes.
And tell the jury a little bit about how that came about.
Well, okay, quick. The way it came about was that I had received a notice, and the notice was that they wanted medical records, and so I was wondering what that was all about.
Okay,
So I called. I found out it was Dr. Smith there at the hospital that was doing the investigation.
okay,
So I called, and she wasn't immediately available. She called me back.
you have a conversation with her then?
Conversation, right? And I thought this is going to be easy for me because on my committee I have a scientific advisory committee. I'm the chairman of, and she's on my committee, Dr.
Objection, Your Honor. This is not responsive to the question.
Yeah, I
Let's
think
get
this is
the
good.
next question.
Right. Let's pull up then 2118-036. I believe it's partially redacted. It's a note from October 11th, 2016.
I don't
It's
believe
2118-036.
is in.
This is not it. That's not it.
It's not?
Yes, it is. Within this morning.
I thought it was 36, 37.
Yeah, this is 36.
I thought you said 26. I'm sorry.
No problem. 2118-36.
Okay, my apologies.
We can publish that with the court's permission.
36.
Who called who, by the way?
I called her.
And through the course of this, then you had, I gather, a conversation about the Kowalskis.
Yes.
And what was your concern here, having received the request for medical records and knowing that Maya was over now at Johns Hopkins All Children's Hospital? What's your general concerns about this?
Well, the day before, I had sent a message to to Beata, the mother, and I hadn't heard a while from them, so I was curious what was going on. Then I get this note for records, and I'm going because I want her to come to see me to reevaluate Maya, and then they're asking me for records, and I don't know what was going on. So I called and talked to Dr. Sally Smith, and she represented herself as being a part of the medical staff there at all Children's.
Excuse me. Objection. Hearsay is called the witnesses editorializing about who she's associated with.
Party admission.
Well, I'm going to overrule that objection.
Let's look at, and what I'll represent to you is a personal note from Dr. Smith of October 11th, 2016, and ask you to review that, see if it refreshes your recollection as to the different topics that at least Dr. Smith took down here of her call. So what did you discuss?
Excuse me. Objection, Your Honor. The witnesses said he didn't have a recollection of this. He's being shown somebody else's record to comment on it or
Speaking of
interpret.
objection.
Let's go to only legal bases. Do you recall the conversation?
Yeah.
So you don't need the notes to refresh your recollection?
I did it right after the conversation. I documented a memorandum.
That's not in evidence. We can't talk about this.
Okay,
It would just
all
be
right.
this.
Well, I can remember what's on the memorandum if that's helpful.
Okay, then,
Why don't we take this down and then
Right.
you
I'll
just
just have
answer Mr. Anderson's specific question and only the specific question.
yes. Tell the jury what you told Dr. Smith. First, I'm sorry. Did she ask you any questions before you told her things?
No, she didn't ask me anything.
What did you tell her?
I
Hearsay, Your
said,
Honor.
Overrule.
You can answer.
I wondered what's going on. I understand you're with, Johns Hopkins, and tell me what's going on with the child and why I'm getting asked for records.
Did she give you a response?
Yeah, yes, and I can't remember the exact, words, but basically she was saying that there was a doctor over the weekend that saw the child and was concerned because when they lightly touched the skin of the child would jump, and that didn't make any sense to them. And they mentioned something about, well, that didn't make any sense, and it was not just in one area; it was pretty much both upper and lower extremities, and that didn't make any sense. And they were concerned that by the history that had been taken, that this might be some kind of a child abuse situation, and that really got me very concerned about the situation.
Before you tell us what you told her, in your experience, is it common or uncommon for doctors not familiar with CRPS to jump to a psychological conclusion before finishing
Oh, they can't wait to object.
differential diagnosis?
Correct.
Legal basis.
Irrelevant, overbroad, vague, has nothing to do with the situation that we're addressing.
Overall evidence.
Yes, it is, because this is a neurological disorder, and it has some signs and symptoms, and it carries with it a history. And if you don't know about that, it may seem a little bizarre. How is it that this child can have this sensitive skin all over?
So you'd seen
And-
this happen before, where?
Oh yeah.
And so to, I guess, to protect your patient, what did you tell Dr. Smith?
Well, when she suggested the Munchausen by proxy, and she did mention that, I said, well, with due respect, she has multiple objective findings that far exceed the criteria that we accept as a standard of care right now, the Budapest criteria, far exceeds those requirements.
So you told her about.
I said, it's absolutely clear. There's nothing, this is it. This is what you got. And I said,
So hang on, so you told her about the Budapest criteria? That was the standard?
right, that was the standard of care.
Okay, and then,
Leading, argumentative, and need to have questions being responsively answered.
I'm gonna overrule the leading, and let's just make sure you answer only the question that's asked.
I'll give you cues there. All right, so now I forgot where I was.
Goodbye, Patroness Glow. Thank you for joining. And Heidi Cakes too. Thank you for joining as well. I'll get to those later, but I just wanted to say quickly because Patroness Glow is leaving, so I want to get that in.
I was asking, did you provide Dr. Smith with the criteria to use in evaluating CRPS?
I did. I pointed out my findings, yes.
Did you tell her how your findings met up with the Budapest criteria?
I did.
Did she say anything?
No.
What else did you tell her?
Well, I emphasized that the findings were objective, could be easily verified, assuming, stating that this is not something that's my opinion. It's really something that's documented, not just by me, but in the scientific literature. And
Jack Bolstrom.
Do you know what overall? Do you know what Dr. Smith's specialty was? What kind of doctor she was?
Pediatrician.
And so, was that a concern to you that whether she had the training or ability to recognize this, or should you have been able to recognize it as a pediatrician?
We're talking recognize the CRPS.
Yes.
I don't think the average pediatrician would. Well, no, I wouldn't say that. It's just that. I got the impression she just didn't really know hardly anything about what we were talking about.
Okay.
But I think most pediatricians, because this is the most painful disorder you find in kids, that they would know about it, and especially since the kids come in, as I said earlier, with a very unique picture in front of your face, the dystonia,
Your Honor, excuse me,
so forth.
we're editorializing beyond the scope of the question.
I thought that one was fair.
We're getting perilously close to opinions that this witness does not have the statutory competence to make.
Yeah, overrule that objection, but sir, I really need you to only answer Mr. Anderson's questions without adding on anything.
Okay,
Really,
I'll work on it.
well, I need you to do more than that. I need you to do that because it's
Okay.
really important that you do that.
Sure.
I'll work on it. He's like, yeah, well, I need you to do more than that. I need you to actually do it. And was Dr. Sally Smith actually a pediatrician, or was she a child abuse doctor? And told him she was a pediatrician. I'm not sure of the answer.
Did you warn off Sally Smith from accusing this family of Munchausen by proxy?
Yes.
And did she respond to you with any particular questions about what these symptoms were or why you were warning her off?
No.
Did you tell her about the allodynia?
Yes.
Did you tell her about the dystonia?
Yes.
Did you tell her about temperature changes?
Yes.
Did you tell her about the, and I'm not sure you documented this, the sweating or any other symptoms and signs that you had noted?
I don't remember those in particular, but the ones that I had documented, I did reference those to her.
All right. And so after, how long was this conversation?
I would estimate maybe 30 minutes, something like that, approximately.
And did you explain to her about generalized neural sensitivity?
Yes. Oh, yes.
And so after all of this, again, any response from Dr. Smith of an inquisitive nature about what the distinction was between Munchausen by proxy and CRPS?
No.
Now, in follow-up to this, did you have any more communication with either Dr. Smith or the hospital about this situation? The situation being Maya Kowalski in the hospital and a diagnosis of Munchausen by proxy as to the mother.
No.
The embolism you spoke about before. Did Beata Kowalski question you about this, I don't want to call it phenomenon, but this circumstance that this embolism was a danger potentially to Maya?
Yeah, she did query me on that.
And did she continue to follow up about this?
Yes.
What did you tell her? Strike it. What did she tell you about her concerns over improper care of her daughter?
I think her concern was her.
Hearsay and standard of care.
Overruling the standard of care, I think I'm going to sustain the hearsay nature of that question, though.
3 or 4, 803, 3 or 4 was the.
I don't think you've got a foundation for that question for that exception.
Did you still consider Maya Kowalski under your care?
Yes.
And were you attempting throughout this period to keep yourself apprised of Maya's medical condition?
Yes.
Did
Objective foundation, Your Honor. The record will reflect this witness had last seen the patient 10 months ago.
Let's, again, no speaking objections, so let's not do that.
I'll be happy to approve.
I don't need an approach on this one. I'm overruling it. You can continue.
And from time to time, did Beata Kowalski provide you with updates on how Maya was doing over the course of the spring and summer of 2016?
Yes, sir.
Did she continue to use you as a source of information about Maya's progress and symptoms and treatments?
Yes.
So at this point, when Beata called you in the fall of 2016, was it for the purposes of updating you about Maya's care and her concerns?
Objection, Your Honor. He's asking for the state of mind of another.
sustain that question.
What, if anything, was the purpose for that last call in the fall of 2016 between you and Beata Kowalski?
Same objection.
Overruled that one.
I'm not sure what date you're talking about here.
Did you have, during the fall of 2016, did you have any conversations with Beata Kowalski where the topic of this embolism starting in the leg
Okay.
was addressed?
Well, that conversations was before then, but yeah, she brought it up. She mentioned that her legs aren't moving. What is she going to get clots down there?
And to the best of your knowledge, did she participate in various, strike that, with this disease? Were there chat rooms and websites where CRPS patients and their child, parent could go to exchange information about the disease?
Yes.
And to the best of your knowledge, based on what she told you and your own knowledge, did Beata Kowalski participate in those from time to time to learn about CRPS?
Yes.
Actually, Hearsay Foundation.
Overruled.
So in this conversation then, did Beata ask you any questions about what would happen to her daughter if she continued to have care that was inappropriate to treating her CRPS?
Yes.
You're on a memory approach?
Yes.
All right, they're going to approach. So let's give them a minute and let's check out some of the comments. Oh, thanks, Marianne. I miss seeing you guys too. It's been really hard with everything that's going on in the news right now to feel like I could come on and do a live stream when there's so much horrifying things going on in Israel and Palestine, and really prayers up to everyone in Israel and Palestine, all of the civilians who are being caught up in these horrible, horrifying acts that we're seeing on TV. And it's just, when I saw this on today, I figured if you guys are watching it anyway, let's watch it together. But there wasn't anything really that I thought I could come on and talk about that could even compare to the horror that's happening on the news. And that's just really terrible. Callie Dime, hello. But it wasn't the actual K medicine that was the issue, I thought. I was under the impression it was the amount of K medicine that was given that was the actual issue. Well, I think that the hospital's position is going to be that the fact that Beata was demanding K treatments at all in any amount was equal to or was manifesting as CA, hence their diagnosis of MBP for Beata. Oh, Dennis, that's what you said. Ketamine is no joke. They gave it to me to do an MRI. I was seeing dragons and fighting with nurses. Nerve tests are not fun either. Jennifer Mossert, with many types of pain treatment medications, you have to break the pain threshold. Sometimes that takes higher doses initially, and then the doctor can lower the dose. It's true. It's true. Anybody who's been through chronic pain or lived with anybody who has had chronic pain understands that it's a process.
Any other questions,
Okay,
Mr.
go back.
Anderson?
What was Beata Kowalski's concern expressed to you in this conversation?
About blood clots forming in her feet, in her legs.
What happens if those go untreated?
I think I mentioned that it's a silent pulmonary embolism, goes to the lung, and could be fatal.
Did you tell Beata Kowalski this in that conversation?
Numerous times when she asked. And the other part of it, Counselor, is that I emphasized that if she doesn't get the ketamine, it's gonna be a slow, painful death.
No further questions.
Members of the jury, we're gonna take a hopefully no more than 10-minute break. Let's try and
Okay,
keep
that
10
is the
minutes to
end
discuss
of
these
direct
subjects,
examination.
investigation, and receiving information.
So let us
All right.
fast forward to the end of that break if you guys still want to watch this together. Heidi Cakes, thank you for becoming a new member. I appreciate that. I have questions. He seems like a very competent doctor. Most experts, when testifying, I can't understand. I bet he's got very good bedside manner, especially dealing with children. You know, I think you're right. You know, the way he's looking at the jury, he's engaging with the jury. He's explaining things in a very down-to-earth manner that they can understand. I think that he's coming across as a good witness. We'll see now what they do with their cross-examination. And here we go. I fast forwarded it to that portion after their break.
Anyone approach you, is that correct?
Correct.
And did not see any media snippets or anything like that. Okay. Mr. Hunter.
Good afternoon, sir.
Good afternoon.
Let's see, you described for the jury earlier your background and training. You're not board certified?
No,
Not board certified in either anesthesiology or pediatrics?
correct.
You've never been board certified in anything?
Correct.
You weren't telling the jury that there wasn't a board certification when you went through residency, were you?
No, I didn't say that.
Okay, there was.
There
correct?
was.
But you're not board certified, never have been.
Correct.
You don't have any hospital privileges at this time?
Correct.
Haven't had any in a number of years, correct?
Correct.
And your clinic, institution is on East Bush Boulevard in Tampa?
Correct.
It's out near Busch Gardens?
Yes.
You have not done any specific research with respect to the pediatric population, have you?
Specific, just only pediatrics?
Yes,
That's
sir.
your question?
Yes. sir.
No, I have not.
And you're aware that ketamine is not known to be safe or effective in pediatric patients below the age of 16.
I don't think that's correct.
Doesn't the manufacturer admonish you that the safety and effectiveness in pediatric patients below the age of 16 has not been established?
Oh, sir, if you ask the question that way, yes, I agree. I agree with you.
Let's talk about the first time that you saw the Kowalskis. By the way, where are your medical records?
I think they're on my computer. They are on my computer.
Where would that be?
On my laptop. It's right now. It's back at the hotel.
So you came here today to testify about this case before this jury without your medical records?
I was told that they had that what's in evidence is my records,
Okay.
my medical records.
Okay, so we'll work off that. The records we have.
Okay, that's kind of it's kind of a jerky question. He's not supposed to bring his medical records to court unless he's told to bring his medical records to court. Everything that's already been agreed on as evidence is in the possession of both attorneys and the court. In fact, his entire file is in the possession of the defense attorney. So to, snark on him for not bringing his records is a little bit in poor taste, in my opinion.
Suggest the first time you saw these people was September 23rd, 2015. Is that right?
Yes,
And before that date, you'd had no communication with them, right?
correct.
Having done the objections?
Oh, shoot. The way he also just said, these people, you first met these people back in 2015. That was kind of, I don't know. Tell me if that's off-putting to you. Or if I'm just being overly sensitive.
Incidentally, you were the first one to diagnose CRPS,
Let's go back a little bit.
and you were the first one making a diagnosis of CRPS. when you went through residency, right?
No, I didn't say that.
Okay.
Specific, just only pediatrics? Is
Yes,
that
sir.
your question?
Uh,
They are on my computer,
Where would that be?
on my laptop. It's, right now, it's back at the hotel.
So you came here today to testify about this case before this jury without your medical records?
I was told that they had, that what's in evidence is my records.
I hope they clean that up on redirect, and I think they will. But again, I just don't. Yeah, this is the defense attorney Scott questioning now, and I just don't think that it's. I just don't think that it's the right way to start.
My medical records.
Okay, so we'll work off that. The records we have suggest the first time you saw these people was September 23rd, 2015. Is that right?
These people.
Yes,
And before that date, you'd had no communication with them, right?
correct.
And you knew that they had seen a number of other physicians, correct?
Yes,
Okay. And you described for counsel the examination you conducted. You knew from the mother that there was thought to be a psychogenic component to the patient's pain. Is that right?
by history, correct.
Okay. And you knew that the patient had been seen at Tampa General Hospital?
Yes,
You indicated you were familiar with the program there.
yes.
Know the doctors involved with it?
That I'm not so sure of. I'm not so
Okay.
sure.
Well,
And in fact, I'd have to say probably not. I remember looking at those records, and I don't think I remember recognize any of those names.
well, you didn't see the Tampa General records before you did your examination and diagnosis on September 23rd, did you?
Probably not. No,
As a matter of fact, you told the mother you didn't want to see it. Is that right?
no, that's not correct.
It's not correct?
No, it's not correct.
Okay, we'll get back to that in a second. But in any event, you didn't speak with any of the doctors at Tampa General, did you?
No,
And you knew that the patient had been seen at Lurie Children's Hospital, correct?
correct,
You knew Lurie's was a pediatric hospital?
correct,
You never spoke with any of the physicians there, did you?
correct.
And did you ever speak with a Dr. Wyndham regarding the patient's immunodeficiency status?
I don't recall that.
Well, you were told that the patient had a selective immunodeficiency, weren't you?
Yes,
But did you talk to the allergist or the immunologist who diagnosed it?
I don't recall that.
Did you talk to Dr. Kreisman at any point?
No,
Did you talk to Dr. Wasnauer, the patient's general practitioner?
I don't think so.
Okay. Were you aware at the time that you made the diagnosis of CRPS in this patient, that this patient had seen over 36 other physicians about her pain and condition?
I don't know the exact number.
You knew it was a good many, didn't you?
Yes, sir.
Did you talk to any one of them?
Well, I don't remember the list. I mean, so I don't recall that. I don't recall talking.
You
to them.
had a patient in front of you who dozens, literally dozens of other doctors had seen and treated at length. And you were the first one making a diagnosis of CRPS, correct?
Correct,
You're the Lone Ranger. You're the first one that came up with that.
correct.
Did you call any one of those doctors and attempt to reconcile your diagnosis with all the other diagnoses that had been made regarding this patient?
No,
The Lone Ranger, he calls him. The Lone Ranger. Anyone in the chat right now who has CRPS who can tell us how difficult it is to diagnose and how so many doctors don't know about CRPS and or how to diagnose it? And because she already saw 36 doctors who didn't diagnose it, does it make him look bad that he didn't call those other doctors if they're not familiar with CRPS? I don't know. Let me know what you think. Before that we do that, thank you so much, Bree Church, for your super sticker. I appreciate you.
Incidentally, you were the first one to diagnose CRPS
Yes, sir.
on September 23rd, 2015.
Yes, sir.
How do you suppose it was that the mother thought that was the current diagnosis a week before, on September 16th, 2015?
Again, the mother. The mother. He's referring to her as the mother. And just as someone who's not emotionally involved in this case, this is not my family, I'm not representing either side, but for him to just refer to her as the mother, it comes across to me as a little condescending. I'm just saying.
Before she saw me on the 23rd of September,
Yes, sir.
I'm not aware of that.
Well, could we put up Joint Exhibit 2012, 25 and 26, please?
Yeah, great team, Brittany.
Yes. Joint Exhibit. My copy says Joint Exhibit at the bottom.
The 2000 series is not joint.
I beg your pardon. I said 2000, 1000. This is 1012-0025. I beg your pardon. Sorry.
I can't read that either,
Wait,
guys.
That's 1012. Okay, well, if you look at the end of the second paragraph on that page, up one, reflex sympathetic dystrophy is the most current diagnosis.
What's the date on that, counselor?
The date on this is September 16th, 2015. It's part of the
September.
records of Dr. Kreisman. Have any idea where Dr. Kreisman would have gotten that history other than from the mother?
Where's the date on this document,
If
counselor?
you go to the first page of it,
Please?
1012-25, you can do it side by side. You look, date of visit, September 16th, 2015.
Somebody's blocking my, I'm trying to read this and they're blocking my view.
Beg your pardon.
Thank you.
Date of visit,
I'm just trying to see how I'm just trying to read the document. So this is page 2. Or what
Page
page?
one.
No, I'm sorry. Page 26 and 28. If we have time, I'd like to read this.
You go back to the first page, please. Can you make it larger, just the first page?
Yeah, thank you. That would be helpful.
You
well, it's a
must-
pulmonary note, doctor, so I'm not trying to belabor what the pulmonologist's findings were, although I want to ask you whether you ever talked to him.
Mr. Hunter,
I'm sorry.
you wanted to look at the document to answer.
Yeah, you don't want to belabor it, but you want him to testify about it. You got to let him look at it. Come on, don't be a jerk.
Okay,
prior
that's
question.
fine.
Can we scroll up a little bit, please? Thank you. Okay, scroll up a little bit more, please. More, please.
You want the next page,
Well, it's,
or you want the top of page 1?
I'm reading it. So go down. So I'm looking at page 25 of 28. Can I see that whole page? I'm seeing part of it here. I'm still seeing part of it here. I don't see the whole,
I
the
think you
rest
need
of
to go
it.
to the next page.
The next page, please. So this will be the next page. Am I correct on that?
You are correct.
Thank you, sir.
I got to hand it to him. He's being very respectful to the defense attorney. I can't wait until they ask him how many times he's testified because he probably has not testified a lot.
Oh, here we go. Okay, this is what I was looking for. So the sentence reads, there is a concern from the mother that the child has selective immunodeficiency. And then the next sentence reads, reflex sympathy is the most current diagnosis.
Right.
So, but it's not, he's making the diagnosis. He's just saying that that's what, I don't know. I don't understand it. It doesn't make any, there's nothing to back up what he's saying. So I don't know.
Okay. But point is, you wouldn't know where he would have gotten that history the week before you made the diagnosis.
I don't know where it came from, sir.
All right. Now, as a result of your visit on the 23rd of September, you recommended that this patient undergo your ketamine infusion therapy 4 days in a row, correct?
Can we bring up that record so I can see what you're referencing?
Hmm.
I mean, there's more to it than just what you just said. I'd like to see what you're making reference to. Could you bring it up so I can see it, please?
What record do you want me to bring up, sir?
You're saying I went from this to that.
No, what I'm saying is, what I'm asking you is, as a result of your visit with this patient on September 23rd, 2015, in which you diagnosed CRPS, did you make a recommendation that the patient undergo ketamine infusion therapy?
There may have been some other things included. That's my point. I'd like to see
Okay.
what else it says.
In that case, if you would bring up the doctor's September 23rd treatment note, which is Joint Exhibit 1056-001.
May we go down on the document, please? Scroll up. Thank
If you
you.
go over to page 2, we can talk about the recommendations you made
Yes,
Okay.
Team Brittany. Yes.
at the bottom.
Okay.
You've told us that you.
Well, wait, I want to read it, Can you bring it up so I can read it?
Right. Don't try and box me into the answer
I
you
wanna
want me
see
to
what I said.
to give you.
Okay. So what it says, sir, it doesn't talk about that, right? It talks about some physical activity, some heated pool exercises. That's the way it started.
Okay, I was going to back up and ask you. You told us,
Yeah,
told
you
counsel,
sure you were.
that you wanted her to try heated pool exercises.
Correct.
And then you wanted the patient to be evaluated by a pediatric internist to determine if there's anything you can do to minimize the risk if you should elect to go forward with the four-day ketamine infusion, correct?
Correct.
Okay. Who was the pediatrician that you had clear her for that ketamine infusion therapy?
Anthony Kreisman.
You spoke with Dr. Kreisman?
No.
Did you ever see a report from Dr. Kreisman about that?
No.
How do you know he cleared her then?
Because I told the mother to go over the material, the basic question, is there anything else that he can do to minimize her risk for the procedure since she has a history of cough asthma?
Okay.
And that was the only question I wanted to know, that if there was anything that could be done to further reduce the risk.
Tell me when you heard from Dr. Kreisman that was the case.
Well, the first time I heard it was from the mother when she came back for an office visit with the child.
So the mother told you that she had gone back to see Dr. Kreisman and to discuss that with him.
Correct.
When did you have her seen by a psychologist?
I did not do that as far as I can recall.
Isn't that something you usually do with patients that you refer to Dr. Cantu?
No.
Isn't that on your website as something that you usually do with patients that you send to Dr. Cantu?
No.
Now, ultimately, you did go forward with the ketamine infusions, right?
Yes. Now, sir, be clear. You're talking now about the conscious sedation, or now you moving over to to the ketamine coma procedure. Where are you now?
No,
Well,
I'm,
you asked me
I'm
about
talking about what you did.
What I did. Okay, no, that's
And you
fine.
never did a ketamine coma, did you?
I've done it, but I've done it before, sure.
But you didn't do it on her, did you?
No, I did not.
You did that in Mexico, correct?
Correct, and I've done it at Tampa General Hospital.
Okay, and you don't do it there anymore, do you?
Correct.
You're not a member of the medical staff there and haven't been for about 10 years, correct?
I'm not sure it's 10 years, but I haven't been there in a while.
Okay. And they haven't been doing that in a while, have they?
No, I don't think so.
When you talk to your patients about this ketamine infusion, I'm going to call it ketamine infusion therapy. Okay? Is that
Yeah.
right?
Can we say conscious versus general anesthetic?
Okay, I'll call
please?
it conscious sedation therapy.
Thank you.
Okay. And incidentally, you want the patient conscious to avoid risk to the patient's airway, correct?
Correct.
Okay. And if you were giving high doses, anesthetic doses, you would want the patient to be intubated to protect her airway, correct?
If the patient was being anesthetized in general anesthesia, yes.
Okay.
Otherwise, don't give me the dose thing because some patients require the different doses. You have to tailor the dose to the patient's needs.
We're going to come back to that. Let's talk about the warnings, the information that you give your patients before ketamine infusion conscious sedation. Okay?
Okay.
You tell them, and we can bring up his consent form if you wish. Joint Exhibit 1056, 0158, and 0159. I'm going to cut to 0159 and ask whether you tell your patients, told the Kowalskis you didn't know if the therapy with IV ketamine will help alleviate the symptoms of CRPS in every patient long term.
Correct.
And you basically tell them in the next paragraph that the more you treat patients with IV ketamine, the more you'll learn about it, correct?
Correct.
And then you warn them that they might have problems from it, correct?
Correct.
And those include infections, correct?
Correct.
Gastrointestinal imbalance.
Where are you reading, sir? I'm looking at the document here. Are you?
I'm reading the third bullet point up from the bottom of the page. Gastrointestinal imbalance and or discomfort and muscle weakness due to ketamine.
Yes.
And then you warn them about loss of weight.
Yes.
And over on the next page, you've talked to us about this, you've warned them about temporary loss of memory.
Yes. And is this the next page now we're looking at?
Yes.
Thank you.
Okay. So with all that, these folks elected to proceed, correct?
Yes, with conscious sedation. Correct.
Okay. Now, I want to make sure I understand how much you gave them. And I'd ask that Joint Exhibit 1055, 008, and 009 be put up. And if you can put those up side by side and highlight the total ketamine at the bottom of this page. That indicates you gave a total of 137 milligrams.
It's what it says. Yes.
Is that correct?
Yes.
And then if we go to the next page, next infusion, which was the next day, 1055, 0012, 011, and 13, we see that you gave 215 milligrams.
That's who he sounds like, Hudson. I've been trying to figure that out. I'm like, his voice sounds so familiar. He does sound like Dr. Phil, doesn't he?
That day, correct?
I don't see anything here, sir.
Oh, I'm faster than my guy, sorry.
My guy, that woman, those people.
I'm looking for the
If you
total.
look at the bottom of 2013, if you'll scroll up some, Clay, on the right-hand side. I thought. So in 2012, I'm sorry, you got 2013, excuse me, 11, I beg your pardon. You've got joint exhibit 105513, should be 105512. Is that correct?
I see it now. Yes, sir. I don't see the date, but I see the number.
Okay. Then if we switch to 10-8 and we go to joint exhibit 105514 and 15, we see that the total ketamine given on the third day is 255, correct?
I see that. Yes, sir.
And then on the fourth day, 10-9, October 9th, we look at 1055, 17, and 18. We see that the last dosage was 300 milligrams, correct?
Yes.
Now, you consider those as high a dose as you wanted to give this patient, correct?
Yes.
And she stayed conscious during this, correct?
Yes.
And you charged the family a total of $10,000 for the 4 days of the treatment?
Yes. Well, plus the follow-up, we don't charge them for coming back and being reevaluated and repeating all the measurements that we did on them, including the videos and so forth. Follow-up, strength and range of motion, pain thresholds and so forth. That's all included. Everything's included. It's not just
Okay.
the 4 day.
So you did an assessment of the patient after that on October 13th?
Correct. That would be probably the following week.
And you said at that point that she showed improved post-treatment pain threshold associated with slight improvement in strength and range of motion, especially in the upper extremities.
I don't see that report here, but
I'll be
what you're
happy-
saying, it sounds reasonable, but I mean, if you
Okay.
want, I can confirm that for you.
I'll put it up. It's joint exhibit 1055-22. So would you have done a video this day?
Let me think. Okay, so the answer is probably yes.
Okay. But in any event, the improvement was slight and the patient was still wheelchair bound,
Yes,
still couldn't walk,
yes,
still had allodynia,
yes,
still had dystonia,
yes,
still had limitation of motion,
yes.
really didn't have any functional improvement, correct?
What the way I worded it was just slight. We have a video recording of this, and if I recall correctly, I believe I commented on the video that that there was some slight improvement, I believe I'm sorry, best I can recollect, in the foot on the left side.
Okay. So the records we have suggest that you next saw the patient on September 2nd. Excuse me, I'm sorry. I beg your pardon, November 2nd of 2015. That sound correct? And I'll ask that joint exhibit 1055-32 be put up for the doctor's benefit.
Okay.
Now, when she came in this day, it was billed as a return patient evaluation, correct?
Yes.
And when she's in your office that day, she's complaining of increasing CRPS pain in her legs, correct?
Correct.
And she was unable to intake adequate fluids and food.
Correct.
She appeared dehydrated.
Correct.
And with that dehydration, even with that dehydration, you were unable to carry out blood pressure monitoring secondary to pain, even with a manual cuff, correct?
Correct.
So you said, you noted that she had a reasonable peripheral pulse for a 10-year-old, but you weren't able to assess her blood pressure, correct?
Well, there is a statement, reasonable peripheral pulses with it for a 10-year-old. For a child that age, she had a blood pressure. I mean, she didn't have, sometimes you see enough kids, you just know that if you were able to get a blood pressure, you were going to get a reasonable blood pressure out of that.
It's always good to have a blood pressure. I think we can agree
No,
on that.
well, I wouldn't I wouldn't say that. If you got a patient talking to you, I don't get blood pressures on them necessarily.
But she's dehydrated
Yeah.
and you can't get the blood pressure.
She had it says
You were,
peripheral.
and you were concerned about the dehydration, weren't you?
Yeah. Yeah.
And as a matter of fact, both the mother and the child were expressing to you suicidal ideations, correct?
Uh-oh.
I don't see this in this report.
Well, didn't you testify to that?
I don't think so. As on this date? No, I don't recall that.
We'll work on that for a minute.
No, he can't trick him. If it's not there, it's not there.
That, can we agree that at this point you thought this child's CRPS, which you had, and incidentally, didn't you rate this child's CRPS disability as severe on your first visit?
I believe so. Yes, but it's to factually state that I would like to see my report, but I'm almost sure that I did. Just thinking about it.
In this report, you indicated that the CRPS she had was intractable, correct?
Correct.
And it had proven refractory to your first care, correct?
Yeah. Very, very poor response.
Okay. And so let's talk about the problems that the patients were encountering. I'll refer you to page 142 of your deposition.
That's exactly what I was going to say, Ann Bazzarelli, is that it would be too painful to put a blood pressure cuff on her to take her blood pressure. And I thought that's where the doctor was going to go with that, but he didn't. So I wish he did, but maybe on redirect, they'll get it.
I'll trade you. This is yours.
Oh, okay. Thank you.
I'm sorry, which page, sir, would you like me to go to?
Well, I was going to go to page 142.
142.
Where you testified as follows. I asked you, but she was able to be touched during the previous infusions. A, yeah, before, yeah. This patient has deteriorated in this situation to the point it's a life-threatening situation, both from a physical standpoint, hemodynamic standpoint, and from the standpoint of emotionally suicidal. And you could not get vital signs that day. Is that
No,
correct?
that's not what. Did you take any vital signs on that date, doctor? Answer. Well, I tried. I mean, remember, I said I couldn't get a blood pressure cuff on her. And we just read here where I was able to get our normal pulses on her.
Okay. But the complete set of vital signs includes blood pressure, right?
Yes, it would.
And your
Yes.
history indicated that she was unable to take fluids, correct?
Yes.
So she's dehydrated, and you have no way to rule out that that's not going to get worse, correct? If she's not taking fluids.
Well, if you read the rest of this, it talks about getting an IV, getting IV access established. Okay, and that was the idea. Get an IV in, because the problem is that I'm trying to remember. This is yeah, I think this was the time we thought that I mean, talking to the mother and so forth, that it would be a good idea to have IV access. I think at this point, if I remember correctly, they were thinking about going to, well, let's say I don't know. I don't remember exactly the context of
Okay.
this.
Well, that's what I was going to ask you about. Because you didn't make a referral to an emergency room that day, did you?
No,
And you didn't make a referral to a psychologist that day, did you?
no,
And you didn't really do anything to give her fluids, did you? You yourself, did you give her fluids?
no. We talked about starting an IV on her.
You also started talking about placing a PICC line, correct?
I can't remember if that was the day we had that discussion or not.
Okay. Well, was that the day that you wrote her a prescription for a PICC line?
It's possible. Again, I have to check the dates of this report, but it's possible that was something that I thought would be a good idea. And
Okay, well, let me
I'm
ask.
trying to put this in the total perspective of what was going on at the time, in terms of the mother contacting Dr. Cantu and there's a lot of moving parts here.
Okay.
And I'm trying to put it all together in my head as we're sitting here.
Incidentally, well, I'm going to ask Clay to put up 1056-211, but let me ask you a question. You've indicated a couple of times concern about pulmonary embolus, correct?
Correct.
Isn't dehydration a risk for pulmonary embolus?
Yeah, I suppose you could argue that, but that's a stretch. That's a stretch.
If you put up 211, you've written a prescription here for a patient with poor IV access requiring chronic treatment of CRPS with IV ketamine requires a 2-lumen line placement for immediate fluid replacement. Is that right?
Yes, sir.
And then you wrote her a script for IV to be administered by the mother, correct?
Sir, do you mind putting that up, please?
I will find it in just a moment, do exactly that.
Thank you.
How about 1056-212?
He can't even be like, he couldn't be more nice, I don't think. Thank you.
Got it. Okay. Thank you.
Patient currently dehydrated with poor nutrition requires fluid with normal saline, 500 milliliters now QD-PRN. In other words, each day as needed, correct?
Yes.
Something electrolyte, something weekly. Check electrolytes weekly, is that
Yes.
right?
Yes, sir.
So you envision the mother giving this IV.
Okay, should we take a break? Should we take a quick 5-minute break? I happen to agree with you because I was just thinking the same exact thing. All right, let's take a quick 5-minute break and then we will come right back. Agreed? And then I want to put it on a little bit, maybe a little higher speed just because it's one of my daughter's birthdays today and we're going out to dinner. So let's take a quick break and we'll be back here. It's 4:44, 4:49. Okay, let's do that. Okay, I'm back. Let's just give whoever needed to go a couple of minutes. But in the meantime, Heidi Cakes, thank you for becoming a new member. Welcome. I think I already addressed that, but maybe not. Also, Rochella, thank you so much for becoming a member. I appreciate you as well. Also, Donna Marie, I know you were the second member. I know. This was an earlier comment from, I think, IE earlier. Are they trying to insinuate that she doesn't have it? Yes, that's exactly what they are trying to insinuate, that she did not have it and that they had every reason to believe that the mother was making it up, causing her to unalive herself after her daughter was taken into state custody for 90 days and her family was not allowed to visit her while she was in the hospital. Ms. Leah, once I was testifying in custody cases, the kid's therapist and the defense said, you only have a master's, you can be considered an expert. And the judge reamed him and said, I say she is. Oh, you're saying they said you only have a master's, you can't be considered an expert? Ridiculous. Yeah, it's up to the judge whether or not he can qualify you as an expert. Yes, Anne, the mom was an infusion nurse. Yeah. And the other thing is that, listen, Johns Hopkins installed the port. They knew she was getting ketamine treatment, K treatments. This was not a surprise. All right, we're going to go back to the stream. I'm going to speed this up to 1 1/4. If that is too fast, let me know. I do see that they just ended about 5 minutes ago, so we don't have that much left, but let's see what we can get through with Dr. Kirkpatrick.
To the daughter herself, correct?
I believe that is correct. She's an infusionist. That's correct. I believe so. Again, I'm trying to recall the details here.
And then subsequently, there was concern about the patient's level of pain, correct?
I don't know. What are you referring to?
Well, I'm having reference to a prescription that you appear to have written, put up, can I show you that? I'm going to have to show you that because I'm not sure this is in evidence. Is 304301 in evidence?
Can we see it? Yeah, is that in evidence?
I thought I was the only one that thought that chat was awful. Thank you guys for being so respectful in the chat. I was watching it on another channel, and that's why I came on to do this myself, because I could not bear to watch what people were writing in that chat. All right, here they go again with their sidebar. So we have a minute to fast forward. They're actually letting him read the records that they want him to testify about. Imagine that.
On to Dr. Cantu, as he described, wound up referring this patient down to Dr. Cantu, as he described.
Yes.
And at that point, she came back to you for a follow-up visit, correct?
Yes.
And you saw her in January of that year, is that right?
I believe so. Yes.
Now, you then have told us you lateraled the ball, if you will, to Dr. Hanna.
Yes.
And I saw no notation in your note that you kept up with her after that. Is that true?
I'm just trying to reflect on that. I don't recall her coming in for an office visit. That was the reason why I had wrote a note the day before Sally Smith. I called Sally Smith.
That's right.
And so I hadn't seen her in a while, so I wanted her to come in and see how she's doing.
That's right, sir.
And the reason you wanted her to come in and see how she was doing was that when you heard about Dr. Smith, You had not seen this patient since January, correct?
No, that's not the sequence, counselor. The sequence is not knowing anything about any problems with Johns Hopkins, without any knowledge of any of that. I just thought, well, listen, I haven't seen this child in a while. She's, whatever, 9 months or so, or maybe less than that. And I thought it would be a good idea to have her back. So I wrote an email to the mother saying, how is she?
I understand. You did that in October of 2016, correct?
Yeah, before I knew anything about Johns Hopkins, just because
I
I was
understand.
interested in seeing how she's doing.
I
Uh-huh.
understand that. You did that before you knew anything about Johns Hopkins. You had written an email to the mother to ask her to come in, correct?
Yeah, I wanted to evaluate the child.
And then you hadn't seen the child by the time you spoke with Dr. Smith, correct?
Correct, other than when she came back from Monterey. Yes,
Okay.
that's correct.
So, excuse me, can I help you also?
Sorry.
So the point is that when you talked to Dr. Smith, you had not seen or evaluated this child since January of 2016 when you saw her after she came back from Monterey, correct?
Correct.
And you hadn't spoken to Dr. Barr about his treatment of her, correct?
I believe it was he the hyperbaric person. I'm trying to remember the names.
No, Dr. Spiegel was a hyperbaric.
Was it? Okay.
Had you spoken with him?
No, I had
And
not.
you knew nothing about hyperbaric therapy, did you?
It's kind of vague in my mind. I don't think so.
And you didn't recommend it, did you?
No,
And you never prescribed any further ketamine for the patient in 2016 after January, did you?
no, she was being seen by Dr. Hannah.
Dr. Hanna. So you may have had some emails with mom about the patient, but you hadn't had any contact with her between October and January, correct?
I don't recall.
Did you ever speak with Dr. Hanna and learn from him that his treatment of the patient had failed?
No, I never heard that.
Did you ever see the patient in October 2016?
I couldn't. She was taken. I don't say taken. She was admitted to the hospital.
Between October of 2016
What date?
and October 7th, 2016.
Okay.
Between that date and January 1st of 2016, January 6th of 2016, you never saw this patient, correct?
Correct.
Now, if I ask you to assume that as of October 7th, this child was in a wheelchair, could not walk, had pain, allodynia in her lower extremities, had dystonia, was not in school, and was basically in that level of functioning, would I be describing the child as you saw her on September the 23rd, 2015?
No,
Why?
because as you noted, Dr. Anthony Kreisman had seen her before she went to Monterey, saw her afterward, and said, this child is totally different. No pain.
No, sir.
There you
I'm
go.
not asking about when.
No, sir, I don't want to hear
No,
anything
I'm talking
good.
about what was being reported, her care under Dr. Hannah. I think that was the
understand
question.
Sir. What I asked you was this. If you assume for the sake of my question that her condition was as I described it on October 7th, 2016, my question was, would she be in essentially the same condition as she was when you saw her, not Dr. Kreisman, when you saw her on September 23rd, 2015?
Based on the information that I have available, she was doing a heck of a lot better.
In what respect?
Well, you read the reports from people that saw her during that time frame.
No, sir, I'm not asking about what happened during the time frame. We'll stipulate that there were ups and downs. What I'm asking you is that in net effect, from September 23rd, 2015 to October 7th, 2016, was there any net change in this child's condition?
From the time I initially saw her, let me see, get your question right. From the time I first saw her on September 23rd, you're asking me what now? I'm trying to understand your question.
My question is, when you saw her on September 23rd, 2015,
First visit.
she had dystonia, correct?
Yes.
She's wheelchair bound.
Yes.
She can't walk. She's non-weight bearing.
Yes.
She doesn't have good function and movement in her upper extremities.
Yes.
She's not in school.
Yes.
She can't take care of her own activities, daily living, correct?
Well, that I don't know if I agree with.
Everything else we agree on, right?
Well, I don't know. You're asking me to lunk a whole bunch of stuff together.
Well, I'm asking you what your examination revealed, sir.
Mr. Asher, you gotta let him answer.
Isn't that what you found in your examination of that patient on September 23rd, 2015?
I saw the patient, again, I'm trying to get the time frame in my head. You're saying from the way her function was when I saw her initially, compared with what?
Compared with October 7th, 2016.
October 2nd, 7th. That's the day she had a relapse, ended up in the morning at Johns Hopkins.
It's the day, several days after her relapse, and she did wind up at the hospital that morning. I'm describing to you her presentation to the hospital versus her presentation to you on September 23rd, 2015.
Okay, I think I got it. Okay, so she has a relapse and ends up at Johns Hopkins with a stomach ache and a recent injury to her foot, and looks like she's got an exacerbation of her CRPS. If that's your question, I would say she was in worse shape than when she entered the hospital. She was having a crisis. She was having acute injuries to her abdomen, acute injury to her foot. That's not what I saw when I saw her.
Go ahead, I'm sorry.
And that's not what I said. So that particular occasion, when she was being admitted, she was worse off when she was being admitted because of some events that took place suddenly. And that happens to be the stomach ache, the injured foot, acute injury to the foot, as well as having her CRPS probably exacerbated by the acute injury she was having, which includes the stomach ache and the injured foot.
What acute injury to her stomach did she have?
Well, it's she had she complained of stomach ache. From what I understand from the hospital records that I read, she came in a kind of a fetal position. And
Did you review the entire hospital record?
yes,
Mr. Hunter, you gotta let him finish his answer.
Yes, sir.
Were you finished with the prior question?
well, I hope I answered the question. She, at that moment in time when she was admitted, she was in worse shape than it was when I first saw her on September 23rd, 2015.
You talked about telling Sally Smith about Munchausen by proxy, correct?
When you say telling her about it,
Well, let me rephrase the question. That was a bad
Yeah,
question.
it was a bad question because that's not what he
You
said.
talked about warning her not to pursue that, correct?
I did.
But you weren't surprised that she brought that up, were you?
In the beginning of the conversation, yes, I was surprised.
Didn't you warn Mr. and Mrs. Kowalski that they might be suspected of Munchausen by proxy the first time you met with them on September 23rd, 2015?
I don't recall that.
You're not saying you didn't, you just don't recall, right?
I don't recall.
And if I understand correctly, you did send this mother an email in the early hospitalization of her daughter, correct?
Yes.
And you did tell her in that email, and instantly, this is after she knew that there was an investigation going on, correct?
The mother?
Yeah.
Yeah, okay.
Okay.
Let's, yes, I don't, yes, I would assume so, yes.
Well, you knew she was very upset.
Yes,
And you told her at that time that if your treatment wasn't adopted, her daughter would die a slow and painful death within reasonable medical certainty.
would you like me to look at the entire communication I had with her at that time?
I would be happy to show you the email that you sent her at that time.
He's so condescending. Is it me? Is he condescending? I will be happy to show you the email. I say this a lot, and tell me if you think I'm wrong. A lot of times cases are won based upon the attorney that the jury likes better. And sometimes it's the lesser of two evils. They have a lot of sidebars in this case.
Moving on.
Yes, Cynthia hit it on the nose. If I could find that comment.
Nothing further this time, man.
Oh, he's done with his cross? Shocking.
Mr. Anderson,
Go redirect.
I'd like to publish 2698. For the record, this is mine from August 11th, 2016.
first off, is this an evidence?
It is in evidence.
Okay.
2698. And doctor, I'd ask you to review this. I'll have questions after. This is
I feel like that cross was a little short. Cassandra. Looks pretty good in the pool to me. I think this was after the return from Mexico. You know, we've learned a lot about CRPS during our following of this trial, and it is one of those diseases that goes in and out of remission. You have good days, you have bad days. Some days the pain is really, really.
I think it's probably enough.
Kate, I didn't know you had CRPS as well.
Doctor, the child you saw, September 23rd, 2015, could that child that you saw then do all that she could do in August of 2016?
Of course not, he said.
Move that freely, appear that devoid of pain, move with that joy when you saw her in September?
Not that joy, especially she was not very joyful when I saw her back in September.
And between that and October 7th, did Maya go into a fairly severe relapse where much of the progress over the intervening spring and summer was lost, at least for a while?
I'm sorry, would you repeat the question? please?
Sure.
Thank you.
No objection
What-
to the question, Judge. Don't specify the time frame when.
During the child, strike it. Are you aware that in September of 2016, Maya had a severe relapse of symptoms of CRPS? First,
Well, this was just before.
just before the October 7th admission.
Right. Well, yeah, I was aware of it just before, correct.
And was that the reason why she looked like she did when you first saw her?
Well, at the time of admission
Yes.
on October 7th?
Yes.
Yeah, she looked worse. She was in crisis, yeah.
But immediately before that relapse, the child looking like she did in the last exhibit, that progress, significant progress?
Oh, of course, she's a whole new human being, yeah.
Now, as to the who diagnosed first, was it your understanding that she saw or heard from her own patient, Dr. Daniels, that his daughter had RSD, and maybe Beata should check that out?
Objection, relevance. Hearsay.
Overall.
Good. It is relevant.
You can answer.
Totally relevant.
I heard something about that, and I don't know, yes, I heard something along those lines, yeah.
When Beata Kowalski came to you, had she already been told there was a possibility of
Yes.
RSD?
Yes,
So this is not about diagnosing her. This is simply about whether she knew the phrase RSD.
correct.
Objection, Leader.
Overall.
That's all, Your Honor.
Objection.
Oh. Oh, yeah. Thanks. You mentioned Dr. Kreisman at Johns Hopkins. Recall Dr. Kreisman? And you recalled something about him seeing Maya after she came back from the trip to Mexico? Recall that,
Yes.
Doctor? And then can we publish 1024 and specifically 1827?
What is it?
I'm sorry. No, that's not right. It's 1024-0030.
Same question.
It's Dr. Kreisman's note from the.
It's a pulmonary. Doctor, you take a look at this and see if,
Objection, Your Honor, can we approach?
Let's take it down.
Take it down. Take it down. I'm changing my opinion. He was a little hard to control in the beginning, but I think he's making a
Second
great
thing is to Read
witness.
to yourself, we're just not reading documents and to the jury.
Right.
Second paragraph, physical exam. Okay, got it.
please read that. Is that what you were referring to when you were talking about
the impression of this Johns Hopkins, all Children's Hospital doctor of Maya once she had come back from Mexico?
Yes. Anything else?
That's it, Your Honor.
Okay, let's take the record down. Any follow-up, Mr. Hunter? Members of the jury?
The moment of truth. Do you have any questions, jury, for Dr. Kirkpatrick?
You know what I'm going to do. Make sure you give Deputy Cooley all of the notes. Did we get all of them?
They have a lot of questions.
We're still working on notes or questions, I should say. Has everyone finished with their questions? Okay. Do not discuss this case amongst yourselves. Do not do the investigation. Receive no information.
All right, for executive.
Okay, we can fast forward now until the judge talks about the questions. Let's just give this a minute. Yeah, somebody said it says a lot how the doctor doesn't need to reference back to any records much to remember her situation. That's true. And that's why, and the fact that he's asking for the records to be able to refresh his recollection is a really great thing too, because he's like, listen, I'm not just going to give you the answer that you want without looking at the records. And isn't that what a good, thorough doctor would do? You know, he's got good credentials. He's been doing this for 40 years. He hadn't treated, I guess, did he say he hadn't treated a lot of patients with CRPS, children? But somebody's got to be the first, right? And also people are kind of harping on the fact that he's not board certified, which I think may weigh with the jury that he's not board certified. But again, we'll see. Scarlett's in the chat. Everyone say happy birthday to Scarlett. Scarlett's birthday. You got in right at the end, honey. We're just gonna talk about the questions that the jury has for Maya's treating doctor.
The doctor was outside our presence, just so you don't have to take my word for it. Okay, Dr. Kirkpatrick, there is a series of questions from the jury. And again, I want you to just answer the specific question and only that question. Okay. The first question, in simplest terms, is it safe to say, unlike an understood and highly researched illness that has almost a flow chart list of symptoms that lead to a diagnosis and treatment, is CRPS still being researched and therefore needs a certain amount of, quote, latitude, end quote, in both its symptoms, diagnoses, and its treatment to be allowed?
Excellent question.
I'm trying to get my arms around that question a little bit. Can you help me, Your Honor?
Well, I think perhaps the lawyers, I think, understand and will ask that question a little bit different way. So let me go to the next question.
Okay.
And the jury said a simple no or yes will do. The designation of, quote, board certified, end quote, was brought up. Is board certified a designation that a doctor knows more, or is it better than a non-board certified doctor?
Well, that's a very good question, and that's to look at in terms of claims, malpractice claims and all that sort of thing. You really can't tell them apart, you know?
Turn his mic back on. They turned off his mic, it sounds like. And this was a great question. And this is the question that we were just asking. He's saying you can't tell the difference. Somebody else said it just means that you pay dues. This is interesting. And 40 years ago, I don't know. So let's listen to this answer.
So you have to remember, though, my situation is one where I trained in anesthesiology over 40 years ago, and it's totally different now in terms of the residency requirements and so forth and so on. And the reason I maintain my academic status all the time, including right now, I'm still academically working, is the PhD degree, because that's what you do. And you got, if you have that skill, you're marketable in the academic field, especially in pharmacology. I hope that answers the question.
Okay, Dr. Kirkpatrick, let's just, the next question I think calls for a yes or no. So
Okay.
hopefully we can confine ourselves to a yes or no on this.
You received a formal request from Dr. Sally Smith of Johns Hopkins All Children's Hospital for your records about Maya. Is that correct?
From her personally, no.
You stated you made a call to Dr. Sally Smith. Did you send the copies of the records to Dr. Smith?
No.
Did you review Maya's medical records before treating her?
Yes.
Okay. And members of the jury, again, if I'm not calling out the question that you sent, that means I can't ask that question. Next question. During Maya's infusions, you monitored her vital signs during the ketamine infusions. Were they within normal range for a child her age?
Yes.
Was that for all of the infusions given?
Yes.
What relation or role does CRPS play in diagnostic, or sorry, let me read it again. What relation or role does CRPS play in digestive issues?
What we know and what my experience dictates is that it does affect the GI tract. And the CRPS affects the sympathetic nervous system, which we say goes into the GI tract, innervates the GI tract. And it shouldn't surprise you that you can really end up with poor function of the GI tract, which includes constipation. And I've seen that many times in patients. And guess what? Ketamine helps that. It helps it big time.
Excellent,
What-
excellent
Or,
question.
sorry, the next question.
Because they are going to try and say that the reason that she had stomach pain was because of the K treatments. And he just said the opposite. He said CRPS will cause constipation, GI issues, and the K infusions will help with that. That's going to be very, very pivotal to this case. Mark my words.
Does obstination have a direct connection to CRPS? And if so, describe the relationship.
Oh, I'm not sure. Other than what I just said about the sympathetic nervous system and its relationship to CRPS, I don't know what else I could add to that.
How many treatments had Maya undergone before you recommended the ketamine coma?
By me personally, is that the question?
Yes.
Okay, for me, it was the 4 ketamine infusions, not to mention my prescriptions to aggressively involve her in heated pool exercises. I found over the decades that that is the most important thing. And if I may, Your Honor, because it's too dangerous. When you have the kind of legs she had, you can re-injure yourself and set off the CRPS again. So lack of having buoyancy when you're in the water is very protective of avoiding a relapse.
Mr. Anderson, do you have any follow-up questions?
May I speak to counsel for responding to one?
Yes, please do. Mr. Hunter,
Yes, Your Honor. I'm sorry. The question.
members of the jury, do you have any follow-up questions? Did I say hand? Okay. May this witness be excused, or does he need to remain under subpoena?
He may be excused. Compliant.
Remain understood.
So what that means is it's possible you might have to be called back, but you are free to go today. So thank you very much for being here.
Okay, thank you.
Judge,
Oops. Oh,
Oh, yeah.
I apologize. You can hang there. Members of the jury, that is going to conclude our testimony for today. So I'm going to let you go. Do not.
Okay, and that's it for the testimony today. I hope you guys enjoyed watching this with me because I enjoyed watching it with you. I know that it was a very small stream today, so I just want to make sure. I know that I'm very interested in this case, and I know that a lot of you are very interested in this case. So if there is any more testimony that you want to watch together, I know Maya testified yesterday. I also would like to go over Dr. Kathy Beatty's deposition testimony, which was played. So if you guys want to watch any of that testimony together, put it in the comments below. And based on, based on majority and what you guys want to watch, I'm happy to come back on and watch it with you. And let me know what you thought about Dr. Kirkpatrick's testimony. I thought it was going to be interesting. And I really have to say that I changed my opinion about him based on a little bit that I watched before we got on this live. So I thought he was a very good witness for the plaintiff, and I thought he was very credible. I thought he was very kind. And I think that he showed that they tried a lot of other treatments before um, undergoing the K therapy. And I think that he did tell Dr. Sally Smith that she didn't, in fact, have CRPS. So we'll see where this trial goes. I think there's a lot more testimony to come, and then we'll see the defense case and we'll see where it goes. But let me know what you think in the comments. Please hit the thumbs up on your way out. Thank you to everyone that has already joined. I did put the memberships up on a soft launch. So I have not even done a video about that yet. I've been so busy. So I will see you guys all again real soon. Thank you to the moderators who keep the chat classy all the time. I love you guys. You're the best. You are the best. So let me know. Happy birthday to Scarlett. We'd sing to you, Scarlett, except somebody made a really nasty comment on my last video about how horrible my voice is and that she pities my children and that it's really easy to go get voice lessons, especially being a journalist. So if you would, go back to my last video on Ruby Frankie and just check out that comment that I pinned to the top and, stick up for me, because it shocks me. It shocks me that adults go online and bully other adults. I'm a grown woman. I don't care. It doesn't bother me, but it gives me a lot more insight as to what our children are facing with online bullying, because it shocks me, really, that people would take the time to actually write such a nasty comment. I also am recovering from COVID, as everybody knows. So whatever. I don't care. I'm not a cupcake. I'm not a cupcake. I'm not going to make everybody happy. If you don't like me, turn the channel. Don't take the time to write some nasty comment in my comments, because I will pin it to the top to publicly shame you. Basically, it's going to happen. Right, Donna Marie? Unbelievable. Thank you. Thank you, Heidi. All right, you guys, let me know what you want to see next. I'm going to put up some, now that we have some members, we'll do some members only stuff. It's going to be really fun. It's going to be really fun. We'll get some merch up. We'll do some members only kind of like Q&A stuff where we'll just talk about whatever we want. We'll just have like a support group. Okay. Because 90% of my audience is women, and we are strong, fierce women who are older, mostly. So we have very little F's to give, and we can like be a support group for each other. We're in the generation where we are taking care of kids and parents. So it's kind of a weird situation that a lot of us are in. So let's do it. Let's do it. I'm here for it. I'm here for you. Whatever you guys want. All right. Sorry if you don't like my voice. Turn the channel. Bye, everybody. I'll see you soon.